In this video, we will talk about hemostatic disorders affecting coagulation factors of the propagation phase. This is when the involvement of the intrinsic pathway occurs, and then the rate at which activation and clotting occurs simply explodes, right? So that is what we want to be talking about. What conditions do we see as abnormal is one of them is hemophilia A. This is deficiency of our non-functional factor 8. Okay, factor 8, that is a cofactor that's needed in the activation of factor 10, right? And its frequency is about 1 in 10,000. It's an X-linked condition where because males have just one X chromosome, it's more common in a male and in a homozygous condition in a female. Okay, so here, obviously, because you do not have factor 8, there is that risk of severe bleeding during surgery. There are different forms of this severe form, then the modest form, and then the mild form. What I have done here is to combine the severe and the modest form. Severe is less than 1%, modest is 1 to 5%. So this is where factor 8 is only about 1 to 5% diagnosed during childhood because of bleeding that occurs in different parts, and then a prolonged APTT, then normal prothrombin time. So then a treatment for it is obviously to replace factor 8. Okay, so it must be controlled, must be normalized before the procedure. Okay, if you know that this condition is severe, it must be in normal levels. Okay, so the half-life of factor 8 is about 12 hours. Factor 8, anybody is a concern. That is, if there was any previous exposure to factor 8, then there could be an antibody, and the replacement of factor 8 may not be effective. So that has to be sorted out as well. And there is a test that we would talk about next. In the mild form, where you have the amount of factor 8 is about 6 to 30%. So this is not going to be noticed until adulthood. And then the APTT is only a few seconds longer than normal, and the normal PT. All right, here you would give synthetic ABP, desmopressin, DDABP is how it's abbreviated. That's going to be given a little before surgery. This is for the mild form, right? Fresh frozen plasma and cryoprecipitate are alternate to factor 8. If factor 8 is not available, you could think about fresh frozen plasma or cryoprecipitate. Okay, hemophilia B, this is where factor 9 is missing. Okay, and not so common as hemophilia A, 1 in 100,000. Okay, so here you're again organizing it to severe bleeding, moderate, and mild. So factor 9 level of if it is below 1%, severe, 1 to 5%, moderate, 5 to 40% is mild. All right, because it is involved in the intrinsic pathway. You're going to be thinking about prolonged APTT and then normal PT. Okay, so easy, replace with factor 9 if this is what is the condition. All right, and mixing study is the test that can be used to identify the presence of an inhibitor or an antibody for factor 8. So what happens is you take a patient's plasma with normal plasma, a 1:1 ratio. Then if the PTT is shorter, then factor 8 is working, correct? If that is replacement of factor 8 is working. And then if there is no shortening of the PTT, that means antibody being present, and therefore it's not effective. Okay, so that's how you look at it. This time we talk about factor 11 deficiency. This is also an autosomal recessive condition, okay, rare, and it is common in one specific population, that is Jews of Ashkenazi descent from Eastern Europe. Because of factor 11 and intrinsic pathway, it affects PTT longer than normal PTT. Bleeding tendency is mild and may only become obvious during surgical procedure. Then what you need to do is to use fresh frozen plasma with factor 11, with deficient factor 11 with active bleeding. So when there is active bleeding, use fresh frozen plasma as a way to correct. Now we talk about missing or reduced or abnormal fibrinogen. Okay, so fibrinogen is a plasma protein that's made by the liver. Okay, if it's lacking, you may call it as afibrinogenemia. A means lack of. Hypofibrinogenemia is less than normal amount of fibrinogen. Dysfibrinogenemia is where fibrinogen is present, but it's not functional. Okay, so afibrinogenemia and hypofibrinogenemia both are rare autosomal recessive conditions. Okay, so now we will look at afibrinogenemia alone. That would lead to obviously severe bleeding, both spontaneously and during surgery. Hypofibrinogenemia is where it's more on the milder side, bleeding only during surgery. Okay. Dysfibrinogenemia is where abnormal fibrinogen due to genetic mutation, autosomal dominant trait here. All right, excessive bleeding. So you need to screen for thrombin time and clotting time, lab evaluation, where measurement of both the concentration and function of fibrinogen. And most of the time, it would be asymptomatic. Okay, in these patients, to correct the situation, you would either use cryoprecipitate or fresh frozen plasma, and you need the amount to be normal is about 100 to 200 milligram per deciliter of fibrinogen. All right, so that is about fibrinogen. Now let's talk about factor 13, also called as fibrin stabilizing factor deficiency. So factor 13 deficiency, as the name suggests, it's the one that stabilizes the clot once the clot is formed. So if you are missing factor 13, the clot that's made is going to be unstable, okay? May not remain in its place and gets flushed out. So let's talk about what could cause this rare autosomal recessive disorder. Okay, it has two subunits. It may be due to the lack of A subunit or B subunit. So as I said, blood clots form but are weak and unable to maintain hemostasis. Okay, newborns with umbilical bleed, circumcision bleed, poor wound healing, high incidence of intracranial hemorrhage. So those are indications of factor 13 deficiency. Fetal loss in women with factor 13 deficiency. So that is 100%. Okay. So treatment is factor 13 concentrate, or even more specifically, recombinant A subunit factor 13. Okay, that's all we want to talk about in the propagation type of conditions that could be abnormal. All right, so we'll stop here and pick up the new set of disorders in our next video.